in this chapter, this one, 6. We're going to talk about bones for 94 more slides. I'm trying to get you excited. It didn't work. Okay, so I don't blame you. Skeletal cartilage is going to be cartilage that's only found on your skeleton. Okay, when we talk about the cartilage that's on our skeleton, it's going to be helping put our bones together. So this entire chapter is going to be about putting bones together. We're going to talk about bones and the cartilage that holds them together. Here I have the term perichondrium. The fact it says chondro or chondri here tells me it has something to do with cartilage. The fact it tells me peri, that means it's on the outside. Okay, so perichondrium. So I know that this is the outside of the cartilage, whatever cartilage is that I'm referencing. Okay, so whenever we have cartilage in a skeletal system, it allows for bending, flexing, and so on. We're going to find cartilage mostly at our joints, where our bone to bone comes together. We're going to end up calling those articulations shortly. There are 3 types of cartilage, and we talked about this last week. There's hyaline, elastic, and fibrocartilage. Hyaline cartilage is pretty much what you're going to find whenever you say, oh, that's cartilage there. It's in your joints. It's synovial joints, where bone-to-bone articulation occurs, or where they touch. Hyaline cartilage in your ribs is hyaline cartilage, so your cartilage there, costal cartilage. Elastic cartilage is going to be in your ears, your earlobes, and your epiglottis. Your epiglottis goes back and forth between your esophagus and your trachea, and I mentioned that briefly last week, but we're going to come back to that. So it kind of looks like one of those stacks on a tractor, and whenever you're laughing and you're pushing air up, it covers your esophagus. And whenever you're swallowing, it covers your trachea, so your food doesn't go in your lungs, and your air doesn't go in your throat. And when it does get mixed up, what do? You cough or you choke, so that epiglottis is like, I don't know what's happening. So you shouldn't eat and laugh at the same time because you confuse your epiglottis. The last type of cartilage is the fibrocartilage. There's 2 main places that we have fibrocartilage. Well, you have it in a few others, but main places. The first one is in between each of your vertebrae. So it's your vertebral cartilage, your intervertebral disc. It pretty much functions as bone in that case, but it allows for a little give, which gives us the flexibility of being able to bend over. Because in the event that our spinal column was just a straight line and it was one bone, we wouldn't have the flexibility that we have. The other place that we have it is in our pubic symphysis, and I mentioned that, where the 2 pubic bones come together in the front. For a male, it pretty much stays immobile their entire life, and for a female, it softens as she gets closer to delivering the child and allows for her hips to widen and her uterus to drop for childbirth. This diagram right here gives you a lot of information. It's a good reference point. You have 2 skeletons by definition. You have an axial skeleton in the middle. You have an appendicular skeleton on the outside. So you can see that they're color-coded. The axial skeleton is the darker brown. The appendicular skeleton is the lighter manila-type color. Then it color-codes the cartilages for you as well. The blue being the hyaline, the green being elastic, and the red being fibrocartilage. 2 ways that cartilage grows. First of all, there's appositional growth and interstitial growth. Appositional growth is when it's growing this way. Interstitial growth is when it's growing in the middle. But cartilage can only grow for a short time because once it's mature and becomes chondrocytes, it's avascular. What does that mean? No blood. So it's set there for life. Okay? Calcification of cartilage. When you were inside your mom, your first skeleton was completely cartilaginous. It was hyaline cartilage. And so they gave us the lining of all of your bones. By the time you were born, it had turned to bone. Okay, for the most part. Some of it was still cartilaginous. But that's why you were so flexible when you first came out. Okay? Until your bones, or your cartilage has completely ossified or became bone, you can't support your own body weight. So as long as there's cartilage there, you're not able to support yourself. That is excluding your growth plates, which we'll get into shortly. Okay, Appositional growth, I already mentioned, is on the outside, interstitial on the inside. Axial skeleton versus appendicular. Axial is down the middle, appendicular is the sides, your upper and lower limbs, okay? And their corresponding girdles. Same skeleton. We have 4 classifications of bone shapes: long bones, short bones, irregular bones, and flat bones. Guess what long bones are? They're long, yeah. Short bones? You see where I'm going with this? Okay. So long bones are longer than they are wide. Okay, for example, like the ulna and the radius, the humerus, the femur, the tibia and fibula. Those are all long bones. They're longer than they are wide. Okay? Short bones are small, short bones. So like you have bones in your wrist. We'll have to learn all those. You have bones in your ankles. We'll learn all those. All right? And those are all small bones. Sesamoid bones. Your patella, which is your kneecap, is not actually attached to your skeleton. It's held there by a tendon, so that's why you can move it back and forth. Some of you have a deep patellar groove, so it doesn't move very much, and some of you can move your patella from one side of your knee to the other. And that's okay, because it's not attached to your skeleton. It's just a tendon that's holding it there. So you're not abnormal if you can do that, and you have nothing to worry about. Flat bones are flat. Your skull bones, all throughout your skull, these are all flat bones. Your sternum is a flat bone. Skull bones. I said skull bones. Flat bones is what I meant to say. Irregular bones are bones that don't have a regular shape, like your individual vertebrae. Those are considered irregular bones. Your coxal bones, which are what we call our hip bones, those are both, you have 2 of them. They are both irregularly shaped bones. Examples of each. So you have your short bones, your irregular, long bones, and flat bones. Questions? What is the function of bones? These. This is the list, and we're going to go into each one in detail. So I'm not going to read it and ask us to discuss it, because I think that we're all in the same time. For support, our bones support and protect our soft body organs. Do you remember what we call our organs? Viscera, yes. As far as protection, we have specific protection for our brain by our cranium. Our cranium does that. Our vertebral column protects our spinal cord. As far as our lungs and our heart, they're protected by our rib cage. Okay, so is every organ protected by our skeletal system? The answer is no. This right here is all very vulnerable. But what we would call our vital organs are all protected by a skeletal structure. Movement, our skeleton functions as a lever for muscle attachment and allows for the movement of our body. We're actually going to spend a section on this today, but mineral and growth factor storage and the calcium that you need. Pretty much every system in your body needs calcium, and we're going to start with that today. Where do we get calcium if you don't eat calcium? We take it out of your bones. You have a hormone that you'll release that will literally disintegrate your bones so that the calcium is released into your blood. So we're going to talk about that today. Your bones are also used for blood storage and production. Most of your blood right now as an adult is not transformed, created. I'm thinking of a word, but I can't think of it right this second. It's created in your femur. So that's why if you're an adult and you fracture your femur, it's such a life-threatening fracture because the majority of your blood is produced there. You also produce blood. You have bone marrow cells in your sternum. You do an autopsy, and a lot of times we'll do a blood tox from your sternum. We'll squeeze your sternum and get the blood out of that. It usually clots up a little bit because you're dead, but still we'll do that there. Hematopoiesis is the production of blood, and we will study that in a further chapter. We're not going to discuss it right now. Triglyceride or fat storage. You have red marrow and you have yellow marrow. And the ends of our bones, which you and I will end up calling our epiphyses, we store yellow marrow that's fat. It pretty much stays that way unless we run out of red, and then we can transform it over. It's a process, but we can do it. Hormone production, our bones produce osteocalcin, and that regulates our bone formation, making sure that it stays homeostatic, that we're producing as much bone as we're breaking down. You're constantly making bone, and you're constantly breaking down bone. And I mentioned that the other day. This is an organ. So the skeleton you have today will be different than the skeleton you have in 3 years. Okay? Bones are organs. I just actually mentioned that. and they work just like the other organ systems. They have a tissue level, a microscopic level tissue, organ level, and so on. There's three levels of their structure. Gross anatomy is what you call a bone, like that's my humerus, and so on. Microscopic are going to be the cells, and we're going to talk about each of those bone cells today. And then chemical level, that's going to be the calcium and the breakdown of calcium and phosphorus, and we're also going to talk about that today. Gross anatomy, you have two types of bones, compact and spongy bone. Compact and spongy bone. Compact is going to be in our long bones, where it's really nice, tight, and compact. Spongy is where it has what we're going to end up calling cancellous or trabecular tissue, or bone. I don't want to say tissue, but bone. And it kind of looks like a sponge in there. Oh, it has it right here. Good. And it's called trabeculae. I'm going to tell you what that's a term that you're going to see a lot. I'm going to show you what that looks like. But when we look at bones, we can say they're either compact or spongy bone. Compact or spongy bone. Let me show you a picture real quick. Here, where this is right here, this is compact bone. It's nice and super tight and thickly organized. Right here, this is spongy bone, and it looks like a sponge, which is why we call it that. But the term trabeculae, which is this right here, trabeculae means it just has all this winding like holes and caves and tubes and so on. There's blood and vessels that go through this. This isn't just an open structure in your body. We have vessels and capillaries that go through it. But when you hear the term trabeculae, this is what it's describing, this type of structure. Okay? I'm going to go back. So we're going to start with the short, flat, and irregular bones. They're usually two layers of compact bone, and they sandwich spongy bone. They're in the middle. Periosteum. Peri tells you what? It's on the outside. Osteo tells you it has something to do with bone. So periosteum is the outside of bones. Where do you think the endosteum is? Inside. Okay? Endosteum is on the inside. And it mentions here that when we're looking at short, irregular, or flat bones, that they have no shaft or epiphysesis. When we look at long bones, the long bones have a shaft. And then the ends of them are what we call epiphyseses. Okay? So that's what this is referencing. It's saying that in these bones up here, you do not have that. We do have bone marrow there in these bones, but there is no bone marrow cavity. Our bone marrow cavity is in our femur. It mentions for the first time articular surfaces. Articular means where bone and bone touch. In a healthy person, where bone and bone touch, there needs to be cartilage. Why? Yeah, the friction. If you have bone on bone, this is going to wear, this is going to be painful. This is what people who have arthritis, this is what they suffer with. People who have overused their joints, like runners, they talk about that they've ruined or run out their cartilage. That's literally what's happened. So right now they're bone on bone, and it literally scrapes across the surface. So articular means where they touch each other, and when we have an articular surface, we want there to be cartilage there to help reduce the friction, okay, and allow for that joint to move smoothly. I've shown you this picture. Diathesis versus epiphysesis. Diathesis is the shaft in the middle. I'm going to show you a picture, then I'll come back. Here is the diathesis of a long bone. This is a long bone because it's longer than it is wide. So we have the diathesis. You can see that it has a cavity inside. Okay, this is the marrow cavity. The ends are what we call the epiphyseses. Epiphyseses. These are the ends of the bones. There's a proximal and a distal end. Proximal means close to the site of attachment. Distal means far. Okay, so it mentions that there. Then you can see right here, it says epiphyseal line. The opposite, not the opposite, but another version of that would be epiphyseal plate. The epiphyseal line tells me that this individual is done growing. This is ossified. This person will no longer get any taller. Okay, that's their growth plate. The epiphyseal line is their growth plate. When it says epiphyseal plate, that means that there's still cartilage there and this individual is still growing. So whenever you take x-rays, if your patient comes in and you take an x-ray of a long bone, and you can see that the break is on the epiphyseal line, this is a horrible break for somebody who is young, if it's still the plate. If you can see some reflection on it, then you know that there's still cartilage there. They won't grow there anymore because the break is right on their growth plate. So that limb stops growing there. It's not a good thing. If it's an adult and I have a break across the epiphyseal line, it really doesn't matter because they're done growing. Okay? And let me go back here. Diathesis, tubular shaft, medullary cavity, yes. Epiphyses are the end. Epiphyseal line. If it says epiphyseal plate, that means they're still growing. And it'll be like a lighter color to cartilage. Too fast. Here, when I'm looking at this bone, this is Trabeculae that I just mentioned on a previous slide. Here is showing you an example of a capillary going through. This right here is compact bone. You can see that it's super tightly organized. So it is very common for compact and spongy bone to be close to each other, or trabecular bone. Right here, this light color, what do you think this is supposed to be? Cartilage. This is depicting cartilage. Okay? So the periosteum. The periosteum is on the very outside of the bones. If you've ever eaten like fried chicken on a bone or even baked chicken on a bone, and you've eaten it all the way down to the bone, you can kind of peel the layer of the bone off. Let me show you what that is. When you can peel the layer of the bone off right here, and you have those little fibers, these fibers right here are called Sharpie fibers. What you're peeling off is the periosteum. The periosteum is the covering of that bone. And if you've done that, that's a really good parallel because it will really help solidify this content. Your bones don't have vessels on the outside, so the periosteum puts blood vessels there that helps nourish and keep the outside of your bones healthy. That's what that purpose serves. Okay? Also in here, periosteum is on the outside. The endosteum is on the inside. This is showing you marrow. It doesn't look this perfect and cut all the time. You can see that right here it's nice and organized, so this is compact bone. You can see trabeculae there. Okay? Let me go back. Periosteum is a white double-layered membrane. It's fibrous or a connective tissue. It has Sharpie's fibers. Those are those little fibers, those hairs that are holding it there in place. It has an osteogenic layer, and I'm going to get into this term in a few slides. So this will make sense in just a moment. But it has osteogenic cells. Those are going to be bone cells, baby bone cells. There's a lot of nerve fibers and blood vessels. This also serves as an anchoring point for for tendons and ligaments. The endosteum is on the inside of the bone, and it just protects the inside of the bone, the trabecular surface. So the endosteum is just on the inside, periosteum on the outside. Both of them have blood vessels that help to nourish that bone. So here's that diagram again. Oops. Red marrow, also called diploid. That's what you see right here. When you have red marrow, that's where you're starting to make blood cells. All blood cells, whether they're red or white, are going to be made in red bone marrow. Where most of us do it right now, it's in the femur. We also can do that here in our sternum. And some of our cranial bones, we can still do that as well. So it mentions where we have that. We have more yellow marrow now as adults, which means we have more fat. In the event that we need more red marrow, we can convert yellow to red if necessary. But that's in emergency situations, not like you don't just do it for the heck of it. Okay?
It's found in adults, it's not found in yellow marrow, it's not found in children.
Yellow marrow can be found in children, but you're going to have, the majority of us right now, we are yellow marrow. Kids can have it, it's just the majority of our marrow right now is yellow. Although we do have red marrow, because you're still making blood cells, you have to. Okay, this section right here talks about bone markings. There is nothing random about the way that a bone is shaped or marks that it has. Okay, so there's a lot of them, and we're not going to cover every single one of them. I just want you to know, though, I'll point out the ones that, of course, you need to be familiar with. But there's like close to 80 of them. But if there's a depression or a curve or some, and it's not because of some type of damage or deformation, it's because it's accommodating a blood vessel or a tendon or a ligament or something like that. Okay, so all of them serve some purpose on the bone surface. We're talking about bone markings here. Like right here on the edge, right underneath your ear, well, behind your ear, that process that sticks out, it's pointy. And normally I have a skeleton and I can point this out and be like, oh, okay, I see it. But these bones right here are very pointy. And the reason they're pointy is because all of these muscles attach to them. And so they have to be. It's like an anchoring point. It kind of lets them hook onto there. Your vertebrae are all pointy in the back, and that's because you have a ton of muscle and ligament that are attached to them that allow for your flexibility. Every bone, curve, mark, groove, all of that, it's meaningful because it's helping you all fit together just like a puzzle. So it's mentioning that here. These next few charts go through all the different bone markings and tell you kind of what they look like and then show you an example of it. Okay? Like we're going to learn epicondyles, condyles, and all that, and I'll bring the skeleton in here when we actually do all that labeling. We're not going to do that today. We do that on the next day that we're together. But each of those, like right here, this has a purpose. Okay, this is going to serve a purpose. We're going to talk about that. Right here, this ischial tuberosity, that's your butt bone when somebody says you have a bony butt. But it's an anchoring point for your pelvic floor, so that allows you to poop and pee whenever you need to pee. You flex all those muscles. Okay, so they're all there for a reason. Continues on with that. The ones you're going to need to be familiar with, specifically foramen. Anytime you see the term foramen, that means a hole. Foramen. Like it's like F-O-R and then amen. Foramen. Those are holes. They accommodate nerves or blood vessels. That's what you're going to see popping up most of this time. Okay? Foramen. I think that may, let's see. That might be the only one I need to point out right there. Okay, so that was bone markings, and I knew that we didn't have to know too much on that. So we're going to move past that. To the 5 types of cells. 5 types of bone cells. Every single one of them has what in it? Osteo, or it says straight out, bone. So if you see osteo anything, it has something to do with bone. You already know what osteoblasts are. What are those? Those are immature or baby bone cells. What are osteocytes? The mature bone cells. So you already know 2 of these. Okay? I'm going to let you guess what a bone lining cell is. It lines the bone. Sometimes our names just aren't that straightforward. Okay? Osteogenic, those are stem cells. Those are bone stem cells. Osteoclasts are the bone cells that break you down. They break down bone. All of these build bone up. This one builds bone. Builds bone down. Breaks bone down. Yes. It builds it down. It breaks bone down. All of these build bone up. This one right here breaks bone down. It is important that you build up just a little bit more than you break down. Why? Why do you not want to break down all of your bone? Because you just won't be here. I mean, it's not a thing. Okay, so we build up our cells. We have stem cells. So these are infants, these are adolescents or baby bone cells. Then here are mature ones. These are on the outside lining, and these are tearing all of these down in a homeostatic manner. Okay? It starts with osteogenic cells, also called osteoprogenitor cells. This is just a fancy word for the exact same thing. Osteoprogenitor and osteogenic are the exact same thing. These are our stem cells for our bone. It tells you that we have some on the periosteum, which is the outside of the bone, and we also have some on the endosteum, which is on the inside of the bone. So we're growing on both sides. Osteoblasts. These are immature bone cells, actively mitotic. So they're going through mitosis, creating more and more bone. So we have stem cells, and then they become osteoblasts, immature bone cells. Here's a good picture of a stem cell. Here's an osteoblast. You won't have to identify those. Osteocytes are the mature bone cells. Mature bone cells are when the bone says, I'm done growing, and they're where they're at. We're going to look at a diagram here in a moment. Osteocytes don't usually divide. If they're damaged, they'll be replaced. We'll break them down. But these are mature cells. They said, you know what? I'm growing. I'm too old for this. They're like the old man on the front porch. Just leave me alone. Okay? I'm just going to sit here and do my job. Okay? Osteoclasts, it mentions here, and we'll come back to them again, but osteoclasts are used to destroy that bone, to break it down. Bone lining cells literally line your bones. So you can either line the bones on the outside, periosteal cells, Or you can line your bones on the inside, endosteal cells, on the inside lining. Okay? These are ultimately just trying to maintain the internal lining if it's on the endosteum, or the external lining if it's periosteal. Okay? That's just what they're doing. They're maintaining the integrity of that outside tissue. Osteoclasts, the last type of cell, are responsible for breaking down bone. And when they break down bone, they engulf it like a macrophage, like it's not supposed to be there anymore. Okay? So they're not just trying to leave wastes in your system. So it mentions that they rest in a resorption bay and they have a ruffled border. I'm going to show you what that looks like. This is an osteoclast. You can see it has multiple nuclei. It's kind of big. It kind of looks like a big broom or a vacuum or a mop type thing. It just cleans up all these cells that aren't supposed to be here. This is what a mature bone cell looks like. I look at it and I'm like, that's that old guy on your porch. It's like, no, I'm going to just sit here and not do anything. But maintain my front porch. And he will maintain your bone. Okay? I'm going to show you the picture before I show you all these terms. First of all, in your long bones, I don't know how many of you are familiar with rebar, which is like a metal reinforcer for concrete. The lines on rebar look very much like this. They kind of go back and forth. The reason the lines don't all go the same direction is because if they all went the same direction, those would be weak points. It would snap there. The fact that they go back and forth in what we call transverse to one another actually gives them a little bit more stability. And your bones, your long bones, are lined in structures like this. These are called osteons that have these collagen lines that go separate or transverse from each other. And that means that your bone can kind of twist and bend and not break. It has a little bit of give and it's reinforced, those long bones. Now, can you break your bone? Obviously. But it takes a whole lot to break it. In the middle of every single one of your osteons, look what colors I have there. Red, which tells you oxygen rich. Blue tells you low oxygen levels. And what does yellow tell you? Nerves. So can you feel when your bones hurt? Yeah, you can. Okay? So I said the osteon. I want to show you the big picture here. Here it shows like each of these is one of these. So your long bones have multiple osteons, and you can see each one has red, yellow, and blue. Each one has red, yellow, and blue. Then even here in the endosteal tissue, you can see that it's woven in there. The terms that you need to be familiar with. The osteon is the whole thing. The lamella. These are up close. Those are just the concentric circles. So you can see a lamella, like those are just the concentric circles. This right here is called the Haversian Canal. That's where you have the red, yellow, and blue. Volkmann's canals with a capital V. I don't even think it's on. Oh, there it is right there. Volkmann's canals. Those are these right here that are connecting all of it. So they don't have just an individual one. It kind of grows and it connects. So they're all connected there. Volkmann's canals, Haversian canals. And those are capitalized because they're named after the scientists who discovered them. Lacuna. Yeah. So right here are mature bone cells right here. These are osteocytes, and you can kind of see where they've stretched into that bone tissue there. So these are all mature bone cells. These are what we call lacuna, just like sitting there. These little lining areas where they're kind of communicating with each other are called caniculi. Caniculi. And you can see your periosteum right here with your Sharpie's fibers on it that you can kind of peel away. I'm going to go back and make sure I've said all the terms. Lamellar bone. Each of these, I already mentioned the concentric circles, are called lamella. But just one more time. So it's called lamellar bone. We have an osteon, which is the individual. It's also called the Haversian system because of the Haversian Canal, which has the red, the blue, and the yellow. It is the structural unit only found in compact bone. So we will not find that in spongy bone. It mentions that they run parallel to the long axis of the bone, that they have lamella, which I mentioned, which are those layers, those concentric circles. They're designed to withstand stress and resist twisting, which is why they go back and forth to one another. So that's that. The Haversian Canal is where you have the blood vessels and the nerves, so the red, blue, and yellow. The Volkmann canals connect them. The lacunae are where you have your osteocytes, and then the caniculi are where the lacuna kind of stretch out, where the osteocytes stretch out and kind of touch each other. That's how they communicate with each other when they talk or whatever. They do talk, but just not like that. Anyway, we don't have to study that today. Questions on the anatomy of compact bone. I know those are a lot of terms. I want to make sure to show you a picture first. Okay, spongy bone. Doesn't look anything like that other one. It looks all crazy, and we call it trabecular. It's very poorly organized. There's no osteons. It's irregularly arranged, and the capillaries just kind of weave in between it to supply that tissue with nutrients. As far as bone compared to steel, bone is half as strong as steel in resisting compression. Bone will compress. Like if you were to jump and land on your feet, you would compress your bones. We have a lot of compression fractures down in the vertebral column as well, where they just squeeze and it crushes those bones. But it's just as strong as steel in resisting tension. But that's the twisting. We can do the twisting part, we can't do the compaction part. Okay? So that's what it's mentioning there. We can see growth arrest lines. We can study your skeleton and actually figure out a whole bunch about you. And we've gotten to the point now in forensic science where we can tell what career you probably had if you did it over and over again because of the way that your bones have worn. We can tell that if you're an athlete, we can tell your handedness. We can tell which foot you are, your dominant foot. And your handedness, like my right arm, my forearm bones will be thicker in my right arm than they will be in my left arm. They'll also have more stress tension on the outside because the muscles will be bigger in this arm than the other arm. We can tell if you typed a lot, which many of us are going to be able to tell now that, because the tops of your phalanges will be flatter. And we can take a tox of your bone and tell what your diet was like. We can tell what you've exposed yourself to. We can do a lot. And as far as breaks or fractures, those never go back to where they look 100% normal. So we can always see scar tissue and tell where you've been damaged before. So if you're sick and you're on antibiotics, a lot of kids who are really young and on antibiotics, their teeth will be yellow, or they'll have a lot of cavities at the top because they don't produce enamel. So that gives us an indication that that child has been sick before. So a lot of times you look at kids and you're like, oh my gosh, their teeth are kind of nasty, or they have a lot of silver caps. It's usually because they were probably sick, had a lot of ear infections as a kid, as a smaller child, and they were on antibiotics, and that stunts that. We can tell so much from your skeleton just by analyzing it and looking into it just a little bit deeper. Ossification is the development of bone. And I already mentioned that we start off with a hyaline cartilage as our skeleton. So our skeleton in utero, meaning while your mom is pregnant with you, begins to develop when you're around 8 weeks along. That's right at that transition point from where you become an embryo and now you're a fetus. Okay? So you've officially made it to the fetal stage, and now we're going to start building bone. You continue to grow bone until you're well into your adult years. I mean, it continues to recycle. Okay? Bone remodeling and repair is where I told you right now, like, you're pretty much done growing, most of us, and your bones, but you can continue to make them healthy and strong by your diet and exercise. Exercise is really important for your bones. 2 types of way bones form: endochondral and intramembranous. Intramembranous is all these bones right here. These bones right here and your clavicles, intramembranous. That means they grow in place. They just grow. These bones here. Endochondral is all of this, the rest of this. All the rest of you grows because it has a mold. It has a hyaline cartilage. So all your facial cranial bones, they all grow in place, along with your clavicles. And every other bone has a bone mold that it forms and it grows off of that. Okay, so intramembranous grows in place, and hyaline or endochondral grows off of a cartilage. Whatever I'm talking about, that. Okay, endochondral ossification is where it's growing based on having a hyaline cartilage form. I already mentioned it's not your clavicles. You have hyaline cartilage. What happens is that hyaline cartilage is broken down and it turns into bone. By the time you are born from your mother, your legs are bone, your arms are bone, your ribs are bone, all of them are bone. Okay? Now, the gaps in your cranium haven't closed yet. Those we'll talk about shortly. But the way this ossification process works, I'm going to go to the picture and then I'll come back to the words. Here was you early. You had this hyaline cartilage. And you started to develop a little bone collar right here. And here's what we call a primary ossification center. This is where your bone growth starts. It takes the cartilage and it turns it into bone. That's what the word ossification means. It means it turns some tissue into bone. In this case, cartilage into bone. You can see here, as you begin to age, that bone collar grows and that ossification center grows. What's going to make this bone take off? What is this doing right here? Giving it a blood vessel, giving it blood and nutrients, oxygen, and now that's going to grow super fast. Once it has a blood vessel, it will grow crazy fast. Okay, it's got its own food source. So you kind of see a slow progression, then all of a sudden you have, full bone. Okay, you can see articular cartilage here. Here's an epiphyseal plate. Epiphyseal plate in articular cartilage. So this kind of shows you endochondral ossification. This is all of these bones, not your clavicles. Let me make sure I said all the words here. Primary ossification center. Ossifies. And I talk about, okay, yes. Very good. Okay, intramembranous ossification. This is all of these cranial bones, facial bones, and your clavicles. They grow in place. They don't have a cartilage form to follow. Okay? They form the bone as they're growing. So you start off with just a couple cells, and then those osteocytes mature. You can see the osteocytes in the center, and then we have more cells growing around it. Then we get a blood vessel, and now we have trabecular bone and compact bone on the side, so these are all flat bones. And flat bones are here, facial bones, cranial bones. Your clavicles are not flat bones, but they are endochondrally ossified. They grow in place, as you are as well. Postnatal, so where am I at postnatally? Outside of your mom. Postnatal, you've been born. Okay? Interstitial growth and appositional growth. Interstitial growth is growing this way in length. Appositional growth is growing in width. Interstitial, appositional. Well, you'll continue to grow in length until your epiphyseal plate is no longer there. When it becomes an epiphyseal line, you will no longer grow this way. Your bones will continue to grow this way. There is no such thing as being big boned in. Like, I just have big bones. That's not a thing. If you truly took a body composition of each of you, your skeletons would be anywhere from 5 pounds to 8 pounds of your body weight, at most. It's no more than that. It's crazy, because I get it. People are like, no, I just have really big bones. You can't have really big bones, because if you had really big bones, then a lot of other systems would malfunction. So it's not a thing, okay? Your bones, the more weight you have, the stronger your bones have to be to support that weight, but it doesn't necessarily make your bones, massively larger. Okay? Yes?
So that whole thing about measuring your wrist and putting on the fingers, that's...
I mean, I'm not saying that it's false, because I'm sure some random person had some science behind it, but I will tell you that the smaller that you get, the more weight you lose, the easier it is to put your fingers around your wrist. So, does that make sense? So, you can be at any size, and if you get bigger, then it becomes more difficult, and if you get smaller, it becomes easier. And because you're losing the fat and the excess tissue around that structure. Yes.
Does the plate turn into the line once it stops?
Yes, ma'am. The plate is, when it says plate, that person is actively growing. It says line, they have stopped growing. Growing has rested.
And then one more question.
Proceed.
Is spongy bone inside of compact bone?
In flat bones. And in,
Oh, that's my bad.
yeah, in flat bones, yes, ma'am. It's spongy, and then compact. Yes, ma'am. But like in long bones, we don't call it technically spongy bone. We call it trabeculae, and it's spongy on the ends. The epiphyseal. But that's a good distinction, and that's a really good question as well. Okay, so this is talking about those growth plates. The epiphyseal plate closure happens when that person stops growing interstitially. For females, this is around the age of 18. For males, this is around the age of 21. That has pretty much, those are textbook numbers, and it has everything to do with when you hit puberty. When your hormone levels get high enough, you stop growing. Okay, but if your hormone levels are still low, and it happens later for men, for them to hit puberty, so that's why they grow a little bit longer, which is why they're a little bit taller. But do we have females that are taller than males? Yes. Okay, so these are all textbook numbers, and this is just reference to that stuff. Okay, this is unique to each individual. We just talk about patterns that we see. Okay, this is showing you how it's taking place. Resting zone here, and then we start to grow. It says calcification, and here we have bone. Here's cartilage, here's bone forming. So it happens in that way. And you can see it's showing you the epiphyseal plate, where it's more cartilaginous, and then it eventually turns to bone, bless you, once it's done growing. Appositional growth is growing wider. And while your bones are growing wider, it's not like growing like inches wider. It's growing like micrometers wider, and we're breaking down the inside of the bones at the same time. So we're not like putting on thick stacks of bone, okay? Because we're talking about microscopic levels here. Ultimately, you're going for thicker, stronger bones, but they're not heavier. So that's what I'm talking about, the whole big boned thing. If you can get a breakdown of your body weight, the majority of your body weight is going to be fat, then muscle, or vice versa, depending on what shape you're in, and then it's going to be water. The smallest aspect of your weight is going to be your skeleton. Like your skeleton is pretty light, okay? Regardless of how tall you are. Just because you're taller doesn't mean you have a heavier skeleton, okay? And this is showing you. So you have this bone here, and then an appositional growth would be it growing wider. Okay, you can still see that this person's actively growing. They're young. That would be an indication that this is a younger person, probably pretty active. When you look at athletes, and we're going to look at a tennis player here in a moment, but they get thicker. Here it's showing you that there used to be bone here, but it was resorbed, like it was broken down by osteoclast, because that individual continues to grow. Your bones continue to grow. They're a very live and metabolic organ. What controls your bone growth? Growth hormone is the main thing. When you have surges of growth hormone impacts bones and muscle. And those two pretty much grow together. Once growth hormone levels decrease or subside, you really stop growing. And they're trumped by your sexual hormones like testosterone and estrogen. So you'll see that. Thyroid hormone. Thyroid hormone, whenever you talk about thyroid problems, issues with that, and I say that because people can relate to those. The thyroid hormone controls every metabolic process in your body. So when someone says I'm having thyroid issues, that doesn't just affect one thing. That affects multiple things. Okay? So, and that would include, of course, your bone growth. Testosterone and estrogens, testosterone for men, obviously estrogens for female. This will happen at growth spurts, and we'll have high levels of growth hormone, and then it will cut off. Excess or deficits of any type of hormone will cause either too much bone or too little bone. There are quite a few bone disorders where there's like haphazard bone deposit, where you look at their skeleton and it looks like running water, but it's like frozen. There's Paget's disease. You can Google all these different things, and their whole back is just a solid bone, or they're off to the side. I mean, there's all kinds of issues with skeletal formation. Bone homeostasis. Your bones are recycled, look at this, on the weekly. Spongy bone is completely replaced from head to toe every 3 to 4 years. Compact every 10. But that's like starting from the bottom and working its way all the way to the top, or from the inside all the way to the outside. So that's a process. Older bone becomes more brittle, and it's easily it gets broken. Okay? All throughout life, there will be bone modeling and bone repair as long as you're healthy. The longer you maintain your health and your vitamins and making sure that you're doing some type of physical activity, staying active is a really big deal. You will have nice, healthy bones, and you will see that the more active you stay, and I'm not talking about running miles, but just going out and being active, playing with your kids, walking your dog, doing stuff like that, you will see that overall all of your systems benefit from this, not just your skeletal system. Okay? Bone deposit versus bone resorption. I already told you that you should be making a little bit more bone, bless you, than you're breaking down, just so that you don't become weaker. Bless you again. Okay? So the bone remodeling units are osteoblasts, which are the baby bone cells they're building up, but at the exact same time we have osteoclasts breaking it down. Importance of calcium. You have to have calcium for not just your skeletal system, which we're going to talk about today. Next week we talk about the muscular system, then we talk about the nervous system, then we continue to talk about endocrine system. They all need calcium. Everything needs calcium. If you don't get calcium in your diet, your body will take it from your bones, which causes your bones to go from being really nice, healthy, and have a really high level of integrity to being very brittle and fragile, and you are very weak. And a way to curtail this, take a multivitamin. You're like, I don't like pills. I don't care. Take a Flintstone. Something. Get yourself some calcium. Take care of your bones. You will thank yourself later in your life. You won't have as many back problems. You won't have any of that stuff because you're taking care of yourself now. You need approximately, these are textbook numbers, 1,200 to 1,400 grams of calcium in your body. And if you don't give it to yourself through your diet or anything like that, it will take it straight from your bones. Okay? And it is so tightly regulated that as soon as the levels drop below where they need to be, immediately you'll start releasing parathyroid hormone. Parathyroid hormone sends a signal to your bones and it says, let's break them down. And it increases your osteoclast activity. So it increases the amount of calcium you're releasing into your blood. Your cells take that up for the functioning that they need to do. It happens almost immediately when you don't have enough calcium. Take a multivitamin or drink yourself a glass of milk. If you don't like milk, find something else that has calcium. Calcitonin may also be involved. Calcitonin doesn't necessarily, we don't know that it necessarily breaks bone down. We do know that it has some factor in bone integrity, but not necessarily in the breakdown of it. It mentions that it could possibly lower blood calcium levels. If it lowers blood calcium levels, that means it's taking taking calcium from our blood, which means that instead of breaking bone down, it's actually helping to create it. But this right here is all like, it's important, but what I need you to focus on is the parathyroid, okay? Because that's the one that's going to be breaking you down and getting you those calcium levels. This is showing you that feedback cycle. So if your blood calcium levels get low, showing you low blood calcium, then parathyroid hormone is released, PTH. As a result, osteoclasts begin to break down bone very quickly, releasing a lot of calcium. Blood calcium levels increase, parathyroid hormone shuts off. It's a negative feedback mechanism. Your body says, I need more calcium. Parathyroid hormone says, done. And it breaks down your bones. Balance, which is homeostasis. Calcium homeostasis. Can you have too much calcium and be okay? No. Can you have too little calcium and be okay? No. We call it hypercalcemia and hypocalcemia. Hyper means you have too much. If you have too much, high blood levels of calcium, eventually it will cause everything to contract and you will expire. If you have too little, things won't contract and you'll expire. If you go home and take like 4 calcium supplements, it will probably make you throw up. Like it will make you sick because that calcium level is too low. people have been killed by calcium poisoning because it's really hard to trace. Because your body needs calcium, and so if the levels are too high, it actually causes muscular arrest, like cardiac arrest, and sends your heart into that. So too much or too little is a bad thing. You just want the homeostatic amount. Take yourself a multivitamin, eat a balanced diet. Leptin is your fat hormone. This is the hormone that tells you that you're full, like stop eating. It's released by your adipocytes that say stop eating. And it's pretty active in most of us. There are some people who have inactive leptin, but that's a totally different disorder. Serotonin is your feel-good hormone. This is a hormone that will stimulate you to eat or to sleep, which both of those initiate or stimulate bone growth. So that's why serotonin is brought up here. Because after you eat, you want to rest, and it gives your bones nutrients and helps with maintaining their integrity. Okay? This is showing you how bones are designed to handle points of stress. Right here, like this one, people often think that this is one of the weaker points, but it's actually helping to curtail some of the weight and the stress that your legs experience as a result of all your movements, because you don't just move in a straight line. Here is showing you an example of bone remodeling. Her serving arm, the thickness, it's thicker in comparison to her non-serving arm, because she continues to work that arm out. The muscles tell it, I need a stronger base, so the bone is actually thicker. That's how we know what hand you are, which one you are dominant, because of the thickness of the bone. Same on your feet. How mechanical stress causes remodeling. When you lift weights, when you do something that causes your muscles to work, it puts stress on your bones, and your bones say, okay, I like that stress. And it creates them to be stronger and more resilient. Doing any type of physical activity will positively benefit your bone remodeling. Walk your dog, run with your kids, do something physical every day. I already told you, walk to your mailbox unless it's on your porch, then walk to your neighbors. When you do that, that stress causes those cells to communicate with each other, and it's like, hey guys, we need to keep doing this, we need to keep moving, we need to stay healthy. That's what you need, and you need calcium too, don't forget, a multivitamin. Your hormones also control how or regulate aspects of your bone development. We've already talked about growth hormone, parathyroid hormone. Okay, I'm not going to go back and explain each of those again, but you definitely need hormones to regulate bone growth. What happens when your bone is broken? Well, you've got to repair it. If you don't reset your bone, will it repair itself? The bone will repair itself. Will it set right? No. It just depends on whether or not you reset it right, if you put it in line. Okay, so fractures, and when someone says I fractured something, it tends to people think that a fracture is not as bad as a break, but a fracture and a break are the exact same thing, especially in the science and in the clinical world. So a fracture and a break is the same thing. Okay, most of the time if you're young, the reason you fracture or break something is because you did something traumatic, like you fell off your bike, or you fell off a swing set, or you hit somebody, or it got shut, or if you're older, it's usually because you're weaker. Okay, normally geriatric patients, when they fall, they fracture their hip, or their shoulder, their clavicles. We have a lot of broken clavicles because they try to catch themselves. So that's normally what we see. Whenever you have breaks, we classify them. Non-displaced versus displaced. If you break a bone and it stays pretty much aligned, we call that non-displaced. But if you break a bone and it shifts, like they're side by side now instead of like in line the way, that's displaced. Non-displaced means that it's pretty much stayed in line. Displaced means that it hasn't, like they're next to each other or they're out of their normal alignment. Complete breakness. Sometimes you make a break and it breaks that bone all the way through, and sometimes you have an incomplete break where it doesn't go all the way through, it just goes partially through that bone. You have open versus a closed or compound. Usually a compound fracture is how it's referenced. That's where the bone penetrates the skin. Like you can see that. That's of course an issue with infections. A closed break is one where the bone is broken but it didn't penetrate the skin, so there's a lot of swelling and bruising and all of that. When you classify a break, is it possible that you could use all three of these? And yes, you could say I have a compound displaced complete break. Does that make sense? So you can use all of those when describing a break. Or you can just use one. It just depends on who you're talking to and what you're trying to convey. Just being familiar with the terminology. Whenever you talk about different breaks, sometimes we can tell where they are based on their name. Sometimes we can't. We can tell about the type of break. So here's some classifications of break. A comminuted break is just where you have a bone that has shattered into a lot of small pieces. In this case, for the most part, it's not displaced. Okay? But you can kind of see where it lines up. You can see a little bit coming off. All right? A compression fracture. Like I mentioned earlier, we see a lot of these in the vertebral column. Like people jump and they land, or they get in a car accident, or they fall, but the pressure compresses that vertebrae. This is a bad deal here too, compression fracture. Okay? And you're only going to find that in areas that would easily compress. So you're not going to, well, you could find that in your skull, but less likely. Here we have a spiral fracture. This is somebody who probably got their arm twisted on something, or maybe a machine, or they fell and twisted. You can see that it's slightly displaced. Here we have an epiphyseal fracture where it fractured on the growth plate. If it's the growth plate, that person's still very young, and that tissue is not going to grow anymore. So a lot of times you'll see these individuals, when they continue to grow, one leg will be longer than the other. It just depends. Here is a depression fracture. This is what normally we reference to as blunt force trauma, where they actually depress that skull or that cranium at some point. Here we have a greenstick fracture. This is an incomplete break. It didn't go all the way through. It just kind of nicked that bone there, so that, it's non-displaced. It's an incomplete break. It's closed. We would just reduce that and put them in a cast. When you have a fracture of any type, the first step is to reduce it. And to reduce it means that you try to realign it. And this can be a very painful realignment depending on where the break is and who the patient is. Sometimes you have to sedate them so that you can reduce it back into its regular. Because if you leave it there, it will heal the way you leave it. So the reduction is a very important part of this. If you have to, like if there's a bunch of shattering, sometimes you have to put pins in there to hold all that bone together while it grows back. But do you leave the pins in there? You can't. So that means that if you have something where you have pins, you're going to have to go in one time, and then you're going to have to go in all the way again to take that stuff out. Because if you leave those pins in there, the bone will grow around those pins, because the bone is a living organ. It's going to continue to make itself. Then after you reduce it, you immobilize it. You stop using it. You don't put weight on it. You allow that tissue to heal. Depending on where that break is and the severity of it and your age, we tell you about how long that's going to take. For kids, we talk about 6 to 8 weeks. For an adult, an active adult who tries to do stuff while they have this break, that can actually increase the longevity of that break. For somebody who's geriatric and they break a hip, they could be down for 6 months or so, 6 to 8 months, just because it's harder for them to get back into the swing of it. This also has a lot to do with the psychological aspect, whether they're motivated to get well or not. Some people they don't want to get well. So, but that also comes with age. Stages of bone repair. As soon as you break that bone, a hematoma forms. A hematoma is a fancy way of saying it's like a bruise. Yes, that's what it is. So we're going to see blood, so it mentions hemorrhaging. We're going to have a clot or a hematoma. That site is going to be swollen, painful because it's swollen, because of the increase in fluids there, and inflamed. So it's usually going to run a fever and be red. Here's an example of a complete break. You can see that those vessels were all severed. There's a bunch of blood there because the blood has to go somewhere, so that's what causes a bruise. Whenever you have a patient come in that's all swollen like this, do you cast them up right now? Why do they make them wait? Why do we wait? Why don't we cast them up right now?
Cast with the swelling, and the swelling goes down, the bones can still shift.
That swelling's going to go down in 3 or 4 days. Their body is going to start metabolizing all of that. So if I cast it right now while it's swollen, it'll be big. And whenever that swelling goes down, the cast will slide right off. So a lot of times they'll put you in what they call a soft cast right here, or an air cast or something like that, to allow that swelling to go down. We do not want to cast up somebody who is all swollen. Okay? Then after that, after the injury, the trauma has occurred, now we work on the healing process. So we want to clean up any of the broken tissue that's there, any debris that's there. We want macrophages to come in and clean that up. We want to start replacing the blood vessels, get them formed, and start reforming that bone. This doesn't just happen overnight. Of course, this takes a few days into weeks. But ultimately, we're going to end up forming a callus around our bone. So here you can see we've cleaned up the mess. I've got my blood vessels back. There's no more bruising here. It's going down slightly. It's still inflamed and still swollen because there's a lot of work taking place here and increased blood flow and fluids. But you can see bone starting to grow. And that bone will slowly continue to accumulate to where it will fill in that area there. Is this ever going to be flat again? No. We will always, always be able to see this callus that this is going to form here. So it mentions that that bony callus starts to form after a week or so. You start to see that callus forming. You can see the bone starting to replace itself, and again, this is a continuous recycling of that. You can still see that it's slightly larger there. The blood vessels are all intact. I have a bunch of spongy bone, but the compact bone is not quite there. Then the bone remodeling occurs, and this continues for weeks, months, years afterwards. Ultimately, what we want to try to do is put the bone back the way that it was. The reality is it won't be. It will still also be weaker at that point, but we will do everything we can to make it fit in the way it used to. Again, you can still kind of see that bone collar there, that callus that shows us that it was broken. And you can easily see that on an x-ray too. I don't know how many of you have seen x-rays of people who have had previous breaks or fractures. You can see that. That's also how we look at abuse cases too. Like we know if that's an old fracture or a new fracture based on the healing process that it undergoes. So this kind of shows you that progression of bone healing from trauma to healed. Osteomalacia. Osteomalacia, so we're going to talk about diseases really quickly. Osteomalacia is where you don't have, you have poor bone deposition. So your bones are very weak. It hurts to walk, so what do you not do? Walk, and then you gain weight, and then it becomes more painful to walk. Then you gain more weight, and we see this happening a lot. Rickets is where you have weak bones, they're kind of rubbery. When you put weight on them, they kind of cause your legs to be bow-legged. It mentions that this is whenever we have it as kids. If you have bow legs as an adult and you didn't have them as a child, it's usually because of activities that you did throughout your life, like horseback riding constantly, and your bones remodeled to that. And you were on like motorcycle riding and stuff like that. We can kind of see that. It's not normally did you have a disease as an adult and all of a sudden you're bow-legged. Although stuff like that can happen. It's not normal like that for that to happen. Osteoporosis is not a specific disease, it's a group of diseases. All osteoporosis means is you have weak bones. That you don't have, that the trabeculae are weak. You have porous bones. It could be caused by a lot of different things. So when someone says I have osteoporosis, that's just like, that's like a pickup line. Like, there's a whole lot of them. Okay? Here's what a healthy bone should look like. Here's an osteoporotic bone. So you can see that there's a lot of extra pores there. This just looks weak. The integrity of that looks horrible. It's very fragile. It's easy to fracture. You can see that there. Risk factors for osteoporosis. Women are more at risk for osteoporosis than men. It's because of their hormones. Postmenopausal, women don't produce hormones anymore. Sexual hormones. So you have to go through hormone replacement therapy is what you need to do. If you don't, your bones do get weaker. And we start to see that these older women fall. It hurts to move, so they don't move, so they gain weight. Then when they do get up, they fall. And it causes a break, and then they're immobilized for 8 to 12 months, and it's just a cycle. Take care of yourself, take care of yourself, take care of yourself. Men can become osteoporotic, but they tend to be more active overall, and their wives are usually telling them what to do. And you think I'm kidding, but there's really studies that say that men will be active because their wives are like, I need this done, I need this done, and they just tend to be healthier because they keep doing that. Technically. There's a lot of men that don't do that, so... Okay, sex hormones are responsible for maintaining your bone integrity. Men produce them once they hit puberty for the rest of their lives. Women produce them when they hit puberty, and they finish when they hit menopause. So then they go through this long time where they're not producing those hormones, and it impacts the integrity of their bones. If you are a small woman, you are more prone to osteoporosis. It's not saying that you're going to get it or that develop it, but if you don't exercise, do what I'm telling you to do. If you have a diet that's poor in calcium and protein, weak bones. If you smoke, weak bones. Hormone-related conditions. If you have a hormone-related condition, there's really nothing you can do about the hormone-related condition. So you're going to have to treat that first. That's the primary cause. This would be secondary. Immobility. If you don't move. If you say, oh, it's too cold, oh, it hurts to move, your bones get weaker. If you don't use them, you lose them. I'm not kidding. This happens to a lot of people. Males with prostate cancer that take drugs to suppress that cancer also have weak bones because it leaches the calcium. Traditional treatments, if you have osteoporosis or you're told you have osteoporosis, you take a vitamin that has calcium. Or you could do that now and not deal with it at all. You could do weight-bearing exercises. You could go through hormone replacement therapy, and that's just a patch. You just put a patch on yourself, and it's taken care of. Small things can improve your life. Take care of yourself now. I'm not the boss of you, but that's what I'm saying. What can you do to prevent getting osteoporosis or developing osteoporosis? You can take a shower. You can eat right. You can do some type of physical activity. You can be nice to people. Okay? So it mentions all of that there, not the nice to people. But weight-bearing exercises, do something. Don't sit sedentary. Paget's disease is that haphazard bone deposition that I was talking about earlier. I don't have pictures in here of that because that would just be something else for me to describe and discuss. But you can Google that and see the pictures of what that looks like. Very uncomfortable looking condition. Developmental aspects of your bones. Remember I told you that you start developing bones 8 weeks in your mom. So you're 8 weeks old, going from embryo to fetus. You start developing bones. You continue to do that all the way until you're done growing, and then you go through the remodeling phase for the rest of your life. So by the time you're 25, you're done growing. That was you at one point. You were so cute. Real quick, all of this is endochondral ossification, where it's using hyaline cartilage as its bone model. And up here is intramembranous. Those grow in place. So we tend to see this skeleton more clearly before we see that skeleton. Okay? And obviously this is not to size. That baby is not that big, but it's up close. Look at his hands and everything. So cute. Okay? Age-related changes in bone. What happens to your bones as you age? Yeah, you're going to see this pattern in every system we cover, unless you take care of yourself. You're going to see the same exact pattern. So it talks about that in children and adolescents, you have nice, healthy, strong bones. Then as you get older, your bones become weaker and more prone to breaking, beginning in the 4th decade. How old is that? 40. Okay? That's too fast. And we're done.